Let's see. Hey everybody, Dr. Leith here, and today I'm going to teach you how to do suicide assessments. Let's get to it. I wish I had a cool calling card. So let's talk about the main principles of suicide assessment. Great article on Blackboard called The 12 Core Principles of Suicide Assessment by Granello up at Ohio State University. And he is one of the leading experts in the study of suicide, along with our very own Dr. Junkie, who's a great professor. If you haven't had him, check him out. He's an expert in addictions and risk assessments. So one of the things that I want you to keep in mind with risk assessment and suicide assessment is that each of these situations is unique. It's unique to the individual and their context. Why am I saying this, right? You might be saying, well, duh. Because unfortunately, there are people who do the cookie cutter approach, right? That everybody who's thinking about suicide is the same, and that's what I want you to get away from. Everybody can and should be treated uniquely and differently, where you're taking into account the specific individual and their specific situation and what's going on. Both the strengths and limitations and weaknesses, the threats, what it means, their resiliency, what led to this, all of that stuff. It's unique. Don't take a cookie cutter approach to really any client situation, but especially suicide. It's complex, and it's not going to have the usual ebb and flow where I talk, you talk, and we take turns. You might have to listen for a very long time. Your client might be very reluctant to speak, or they might be very emotional. They might be talking in circles. You might have to take control and say, okay, I know you want to talk about that issue, but I need us to come back to the issue of suicide. And so it's going to be a little complicated. It's going to push you and them. And that's why I really emphasize how important it is to get comfortable doing this. If y'all saw me the first time I gave a suicide assessment, I was a hot mess. It was really difficult. But through training and supervision and trying to figure out why that was so difficult for me and what I did and what I could do, I've gotten very comfortable with it. But it is going to be complex. It is not like a normal counseling session where we just talk about an issue and kind of take turns in a dialogue. It's ongoing. So I start all of my counseling relationships, that first session, I always ask about suicide. If a person says yes, or if later on they bring up suicide, I always follow up with it. You're always following up with it. We're always keeping a pulse on it. In other words, it's not one and done. You don't just, are you thinking about suicide? No. Cool. And then you move on and never ask about it again. You'll ask at the next session, and the session after that, and so on. We err on the side of caution, right? So if in doubt, make a report. And this is the hardest decision that most new counselors have to make. It's a hard decision for seasoned, experienced counselors to make. The rule of thumb that I have, that I give unto you, is if you think you need it, if you're thinking about making a report, you should probably make a report, right? And the same goes for child abuse or elder abuse and things like that, where if you're like, should I report this? Just go ahead and report it, document it, and report it. I know it's uncomfortable, and everybody is afraid of, what if I report it when I shouldn't have? That is a much better situation than reporting it or not reporting it when you should have, right? Be collaborative. Work with your client with it. I'm transparent, and I say, look, I'm afraid you're thinking about suicide, or you told me you're thinking about suicide, and I'm afraid for your safety, right? So we work together that way. But are there other sources of information? So this is always easy when you're working with minors, right? Because I can talk to mom and dad or teachers or whomever. Can you call family members? Are there emergency contacts? Many times, in my experience, the client, when I bring this up, because immediately you probably go to a place of, what about confidentiality? And that is a valid concern. But asking them, do you mind if I call a family member, and kind of taking the steps so that you can do that. But also with emergency contacts, right? When you're doing your informed consent or your initial paperwork, having a form that simply states, in the event of suicidal ideation or an emergency, who can I call? And letting them know that you're going to call. HIPAA and confidentiality is there if you let them know under which circumstances you can and will breach confidentiality, then it becomes less of a concern. We're not talking about just doing this just for any old reason. We're talking about a life or death situation and having an emergency contact and who should I call to talk about this, right? So there are ways to set that up if you need it. Use your judgment, and this is going to make some people really uncomfortable. Under no circumstance can you take an assessment such as the suicide probability scale, give it to them and say, oh, well, they scored low on it, so I guess I don't have to worry. Or they score high on it and make your decisions. Every decision you make is based on your clinical judgment. Let me get out the pen. Your clinical judgment. Look at that. Yeah. So it's going to come down to what you think about it. You cannot just fall back on, well, the scale told me, right? We use scales and assessment techniques to supplement our clinical judgment. Take all signs seriously. And if we were in class, we'd all have a good chuckle, because I don't know what filler to put in here, like, take all signs seriously. If they're like, yeah, I wish I was dead, don't be like, oh, I get it, right? Like, no, follow up. Like, what do you mean by that? You serious? Right? Ask questions. Don't ignore it. If they're really subtle, just say, and I've had to do this, like, hey, I just want to make sure we're on the same page. Are you talking about killing yourself? Are we talking about suicide right now? What's the worst that happens? Everybody gets so afraid of, what if I'm wrong? What if you're wrong, right? What's the absolute worst thing that happens? They leave, right? They don't want to come to counseling with you anymore. And that's okay. It is much better that you ask and they never want to talk to you again than you don't ask and then they suicide, in which case they're also not talking to you ever again. Ask tough questions. Like what? Man, I really wish we were in class so we could do this together. Questions like, are you thinking about killing yourself? Ask the question. Just do it. Don't pat it. Be personable. Be a counselor. Are you thinking about killing yourself? They say no. You say, okay, that's good to know. And then you proceed. They say yes. What's a good follow-up question? You know, some of you are probably saying, like, how long have you felt that way on a scale of 1 to 10? And then a few of you are probably thinking, how would you do it? And that's correct. Do you have a plan? How would you do it? And if they have a plan, that is more serious than if they don't. It's a serious situation regardless. But how would you do it? Do you have access to those means? They say, well, I wouldn't want to feel any pain. I would shoot myself. Well, do you have access to a gun? Yes. Now it's even more serious, right? It doesn't mean that if they don't, that it doesn't matter. But we got to ask those questions. Do you have a plan? Are you thinking about it? How would you do it? When would you do it? Right? Things like that. Those are the questions that help us figure out the situation. Assessment is treatment. Right? Through this dialogue, it is completely possible, and in my experience, it's often that the situation alleviates. Have you ever been really frustrated about something and you start telling somebody, and as you're saying it out loud, you're kind of like, oh, I already feel better, right? That happens here. That doesn't mean that I won't still make a report, right, or have the person go to a hospital, but it means that they might get to a point where they're explaining and they'll say, I am really upset. This is a big problem, but I don't know. I don't feel like it's as big a problem as it was an hour ago. Or, boy, I guess that really is bothering me. So it can be beneficial in its own way. And even, remember, making reports and having someone go to a hospital is not a punishment. Many clients will feel that way. In fact, you might feel that way. But it is in their interest to help keep them from killing themselves or hurting somebody else. Right? And so, more often than not, in fact, I can't think of a time where I had someone go to a hospital for suicide that did not come back and work with me. Now, some people came back right away, and for some people it was months, if not a year or more, before they came back. Some of them would even say, I'm still pissed off at you about it, but it was the right thing to do. Because it's a rough situation for them to be in. They're already so upset, so miserable, that they're thinking about suicide. It's hard, and to not feel like they have that space anymore can be jarring. At the same time, I've never had anybody not understand that ethically and legally I'm obligated, but more importantly, I am very scared for your safety and for your life, that I want to keep you safe, and that's what I'm doing, whether you agree or not. And it can be kind of a tense situation, but that's part of it. It's going to be the exception where it's not tense. Find the underlying message, right? So, what is suicide about? More often than not, people have gone to a point where they feel like nothing's going to get better. And in my experience, it comes down to one of these three things: communication, control, or avoidance. Many, many, many times, the issue is a communication issue. Meaning that the person feels like nobody takes me seriously, but when I say I'm going to kill myself, everybody listens. And when I started asking my clients about that, or if they're talking in hyperbole, my suicide assessment got so much easier. And how that looks is the person comes in and they bring up suicide. They might even be talking about it, and I'll just say, there are people who they want to commit suicide because they don't want to be alive anymore. And there are people who bring up suicide because they're really frustrated and they're really angry and they're really hurt. But that's not really how they feel. They're bringing it up as a way of communicating how angry and frustrated and hurt they are. Does that relate to you in any way? And by and large, the majority of the time, that's the situation. They'll say, no, I don't want to stop living, but I want fill in the blank. And most of the time, it's to be heard. And then I say, well, is there a way we can talk about the problem that's actually making you upset without bringing up suicide? Because anytime you bring up suicide, that's what I have to focus on, and we can't talk about the actual problem. And a lot of times they're really agreeable to that, because again, it's not that they have a desire to die or a desire to stop living. It's that they want to be heard. So it's being used as a communication tool. It's an unhealthy tool. And yes, I have had people, it's been the exception, I've had a few who have said, no, I want to stop living. And that brings us down to avoidance, which is, okay, well, tell me what's going on. And that's when their life has become so unbearable, the situation has become so unbearable that they cannot think of A, continuing in that life, or B, finding a way out of it. So I'm trying to escape something. I'm trying to escape these feelings of depression. I'm trying to escape the situation I made up with my family or relationship. I'm trying to escape the despair or angst of life, whatever it might be. I want to get out of it. And then there's control, which is, if you leave me, I'll kill myself, right? They're using suicide as a tool to get what they want. And that can be, that is an unhealthy situation. But these are the messages that I typically see. It's either being used to communicate. In other words, nobody takes me seriously unless I bring up suicide. I use it to get what I want, which is unhealthy. Or I'm really thinking about it and I don't know what else to do other than to kill myself. And once we find this message, then we have something to work with beyond preventing suicide, right? We got to prevent the suicide. Working on that underlying message is what keeps it from coming up again. Consider culture. So think of the ways different people phrase despair, right? So the current generation humor is very despairing in nature. The phrases people use, I wish I was dead, I wish I could go to sleep and not wake up. What does suicide mean in different cultures, right? So we're making sure, right, if we're so worried about having someone go to the hospital when they didn't mean suicide, one of the things we can do to prevent that is consider culture, not only in terms of ethnicity or country of origin, but also generational differences and gender differences and things like that. What does suicide mean? What do they really mean in the message that they're telling us? Are they really thinking about suicide? Or again, are they communicating the magnitude of their despair? Document everything, right? So you need to document, I did a suicide assessment, I used such and such technique, this is why I made the decision I did, this is why I decided to have the person go to a hospital, this is why I did not decide to have the person go to a hospital. Those are the 12 principles, right? There's that great article, read it. If you have questions, I'd love to answer them. If you have a reaction, I'd love to hear it. So ways of assessing suicide. There are different informal methods of assessing suicide, but there's not a really good formal standardized method. Because to get it to work, so we're talking about predictive validity, what I would have to do is make the Leith suicide assessment scale, have people score high on it, meaning they're thinking about suicide, and to really clinch it, see if they actually follow through. That's fairly unethical, right? I can't do that, right? If someone indicates they're thinking about suicide, I need to intervene and help them. So we rely very heavily on informal methods. And since individuals who have completed suicide were unable to communicate with them for the obvious reason, we don't really have so much predictors, right, of what will cause suicide or lead to suicide, but we have descriptors. So what do those individuals who attempted suicide or completed suicide have in common? And that's what Sad Persons is based on. And Sad Persons was designed by our very own Dr. Jerry Junkie. Again, I talked about him at the beginning of the video. Great guy. So Sad Persons, nice, clean, simple to use, informal assessment that you can make paperwork out of or write down on a pad of paper that you have in your counseling chair. But for each of these factors, the person either gets a point or they don't. And the more points they have at the end, the higher the risk of suicide. So, for example, sex, right? What is the sex of your client? If they're a man, they get a point. Because more often than not, people who complete suicide are men. Their age, are they younger than 24 or older than 45? If so, they get a point. Because those are the age ranges that suicide attempts occur the most. Do they have depression? And not just DSM depression. If they describe themselves as depressed, they get a point. Have they had a previous attempt? They get a point. And this is a huge red flag. Why do you think that is? Because, yeah, you're right. Because if they were able to attempt once, they are able to attempt again. Ethanol, aka alcohol, or drug use. Rational thinking loss, so losing touch with reality, hearing voices, delusions, and so on. Social support lacking, they feel lonely, right? And so they might have 100 friends, but they still feel lonely. It's if they feel a lack of social support. Do they have an organized plan? Also a huge red flag. No spouse and sickness. So things like cancer, Lou Gehrig's disease, HIV, especially, or chronic pain issues. 1 point per factor. 0 to 2 points, consider sending home. 3 to 4, close follow-up. Kind of think about hospitalization. 5 or 6, really consider hospitalization. And 7 to 10, have them go to a hospital. So with this, just to kind of illustrate why you can't just rely on an assessment. You have to use your judgment. Look at these and think for a second. Is it possible to score high on this and not be at risk for suicide? And is it possible to score low and be at very high risk? And the answer to both is yes. We could have a young guy that's going to college. So 1, 2, he's going through some separation anxiety, so he's kind of down. 3, no attempt. He's in college, so he's drinking. So that's 1, 2, 3, 4. Doesn't have this. All of his friends are back home. 5. Doesn't have a plan. Doesn't have a spouse. 6. And let's say that he does have, he has a chronic pain injury, or an injury that causes chronic pain. Well, yeah, 7. But he never thinks about suicide, right? So 1, we would only be doing a suicide assessment on somebody who's thinking about suicide to begin with. But this is to show that you can have a situation where somebody has a high score but is not at risk. Let's try again. We have a guy who's 30, feels pretty good most of the time. Or let's go ahead and give him a point. He feels depressed, doesn't drink, hasn't lost touch with reality, says he has lots of friends, has attempted before, and he has a plan, is married, and is in perfect health. So he scored a 3, but he's probably at the highest risk because he has an organized plan and he has a previous attempt. Even if he didn't have this, the only 2 points he has are the most serious 2 factors, right? So that's why it falls on your clinical judgment. This is a guide for you to remember to ask certain questions and to ask the appropriate follow-up questions. Another one, if you want something that, because sad persons is dichotomous, right? It's yes or no. We also have is path warm, right? And this table here you can print off. This is, you can just copy it and put it into Word and print it for your records, and you can use it. This is something that I didn't make is path warm, but I made this very cool table. And so, do they have ideation? The description is, I want to die, I wish I was dead, I want to kill myself. And then you can write down comments, right? Stated, I wish I was dead. Substance abuse or intoxication, alcohol or other drug history, purposelessness, so they communicate that they have little or no reason to live, no long-term goals, or maybe they do have a purpose, right? Says they want to take care of their kids. Anger, so high levels of rage, they want revenge, right? They'll be sorry when I'm gone. Feeling wronged. Do they feel trapped, like I have no control over the situation? Hopeless, negative sense of self or others, right? What's the point? I can't do anything. It doesn't matter. Are they withdrawing, right? They're pulling away from friends and family. At school, we might see a lot of skipping. At work, they're not engaging with coworkers. Anxiety, so inability to relax. They're always kind of amped up. Sleep disturbances or disturbances in eating. They're not eating as much. Are they getting reckless? Right, because this might be, well, if I get in a car accident, or if someone kills me in a bar fight, then I don't have to do it myself, right? Maybe this is an easy way out. And mood change, dramatic mood shift, right? So not a bad day, but went from a general personable colleague to someone you can't talk to at all. Huge, dramatic mood shift. Went from smiling to being down all the time. And so you can explore each of these factors to help inform your decision. But ultimately, the decision to report, go to a hospital, anything like that is going to come down to your judgment. And the big key thing here is that tough question of, are you thinking about suicide? Right? And again, it's better to err on the side of caution. So I don't want to leave off on such a heavy note. Suicidal ideation is very common, and it's going to be the exception that a counselor never works with it. However, rebounding from it is completely possible, and it's very likely as long as the person is getting the help that they need. And that starts with us. When they come to us asking those tough questions and getting them the help they need. Sometimes the person is able to leave my office and go home, and we set up a plan and we work through it. Sometimes I can't let them just go home. Sometimes they need to go to a hospital or someplace inpatient where they won't hurt themselves, and then they're able to figure things out, right? They're stabilized, maybe medication is involved, and maybe it isn't. And they come back and they realize, wow, either someone cared enough about me to keep me from killing myself, or I had time to think because I had nothing to do while I was in that place, and I don't want to do this. But when they're given the appropriate tools and the appropriate help, recovering from suicidal ideation and even a suicide attempt is very possible, right? And so I think of survivors of suicide attempts, right? And they come back, and those feelings might creep up, but we're giving them the tools now to navigate it so it doesn't get there, and helping them understand that they're not in trouble because they feel this way. It's not healthy, but they're not bad people for thinking about it, and that they do matter, and they deserve to have a life worth living. And the path to that goal can be long and windy and filled with fog, but it's completely possible to get to that destination. But they have to do some work, and we have to do some work. So don't feel that this is a lost cause, or that because you report or they go to a hospital, they're never seen again, and that's the last note that you're left off on. Like I said, I think nearly 100% of the time, my clients who have wound up going to a hospital have circled back to me, and now they have a little bit more information about themselves. Sometimes medication was needed. Most of the time it wasn't, but they went there and they figured out, okay, I got that close to the edge, and I don't want to go there again. What can we do so that I'm not feeling that way? And that's a really good place to be, where they have buy-in into their own life, so that way they're not feeling that way. So don't ever feel it's overwhelming in the moment, but it is not a hopeless situation at all. It is easily one of the most preventable forms of death. That's going to do it. Hopefully I dug us out of the heaviness of this video. I hope everybody's well. Check out the articles and tools on Blackboard. And if you have any questions or concerns, let me know, and I'll talk to you again in the next video. Bye-bye.